Welcome back to Mind the Back Chair. I love saying that. I do not ever get tired of saying that.
Even if it is so repetitive.
Yeah, but it's nice. We only do it once a week, so make the most of it.
Life is repetitive.
Life is repetitive,
Whoa,
and that can
we
lead
get
to
it
repetitive
covered.
strains, which lead to shoulder problems, which is why we're keeping it simple today with
Shoulders.
yeah, buddy. So we're going to be talking about the most common shoulder cases or most common shoulder injuries that we see presented at clinic.
And let's face it, shoulders are probably one of the most common things that we will see on a day-to-day basis.
And can be considered one of the most complicated things to see.
I mean,
that was good. That eye roll was good.
Let's face it, 27 muscles attached to the scapula.
Crazy.
Scapular shoulder blade.
Yeah.
Right? 27. Nice. So 27 opportunities for something to be painful.
Or get pinched. Yeah.
Which is why we're going to start with impingement.
Impingement syndrome. Okay. So as a person, as an osteopath, as a student, I was never really happy with the term impingement syndrome, and I had a couple of tutors who also agreed, because it's kind of an umbrella term for a lot of other things that we're going to discuss, which are common things as well. Because impingement can be anything from inflammation to degenerative change to bursitis, all going on in the shoulder because so many tendons and muscles pass through such a small space.
And the thing is, I think the reason why so many tutors are so against the use of the word impingement is because you're not being specific enough.
Yeah.
If it is a bursitis, tell me which one it is. Tell me which one are you thinking. And I think when you are in university and you are a student trying to understand, that's when your differential diagnosis really comes into play. So you're doing your orthopedic testing, you're doing your case history, and then using all of those little factors in order to make sure that you're, number one, identifying which tissues are being problematic, what pathologies are you thinking are involved in your differential diagnosis, and how you can structurally understand why you have come up with that decision and that diagnosis.
So there's a lot of thinking, isn't there?
Yeah, it's a whole puzzle.
It's safe to put in your notes, impingement syndrome, because you can put that, but again, it's not being specific. And I was somebody who always wanted to be quite specific with my diagnosis, and I always just saw it as an umbrella term. Yeah, thank you. So one of the main kind of ones that comes with impingement, and people may say like, if I've torn a muscle in my shoulder, how can that be impingement? But the most commonly strained muscle in the shoulder, which accounts for 50% of all shoulder injuries, is the supraspinatus. So when that tears or that becomes strained, it passes through a small gap underneath your clavicle, so your acromion and your glenohumeral joint, so the ball socket aspect of your shoulder. There's a small space there. It passes loads of other tendons, ligaments, nerves, arteries, everything. And so if you have a tear in there and it inflames, funnily enough, that's going to cause impingement. And this kind of leads us to our first major injury that we see in clinic, which is a rotator cuff tear, because the supraspinatus makes up for 70% of all rotator cuff injuries.
And the reason why it makes up for so many of those injuries is because of where it's positioned and what muscles are around it. So when you're looking at it from a biomechanical point of view, unfortunately we live in a very a constant lifestyle of being in front of a desk with your arms and shoulders protracted forward. So what tends to happen with that is you're changing the complete biomechanic of the way the supraspinatus is meant to work.
I always go for the word ideology, especially on treating patients, because we want to, if we're changing your posture at work, we want to change the body's ideology, the muscle's ideology, back to what it originally was.
Yeah, and the thing is, once you've kind of done that and you've opened up a little bit more space in the subacromion, it's fantastic, because then it can move the way it's meant to. But when it doesn't, it becomes pathological.
And one of the easiest things to do is a pectoral muscle stretch and strengthening up your rhomboids just to bring those shoulders back, which classically open up that space, but normally we keep it closed. So it's no wonder if we have these tears and strains going on, as you're perfectly demonstrating, stretch, that these areas can be classed as pinching, because when your shoulder's round, space gets tighter. So yes, rotator cuff is the most common thing you hear. People come in all the time saying, I think I've got a rotator cuff tear from what the internet's told me.
And you're like, which one?
Yeah, because I think we've discussed it previously. I think when we did most common injuries of upper lower body, there's 4 muscles. Now, you originally said this and you got one muscle wrong. So let's see if you've learned from your mistakes, young Padawan.
So, subscapularis, infraspinatus, supraspinatus, and teres minor.
Yeah, good man. Last time you said major, and I was like,
what?
You lied to these people?
Well, it's because it's lady lap between 2 minors.
Ah, wow. That's one way to remember it.
Yeah.
That works for you.
Yeah. Well, that's the way I was taught, and because you've got latissimus, and then you've got.
Okay. Kind of gets a bit complicated, like a rotator cuff tear, because when one muscle becomes strained, because all the rotator cuff muscles do is bring support to the area, don't they? They attach the shoulder to the body and allow it to have movement, basically. And when one of those muscles becomes dysfunctional, your shoulder's basically losing a critical muscle doing a critical job, so all the other muscles compensate and they also become painful, and that's when every movement's really sore and uncomfortable. With regards to rotator cuff tears, there's actually multiple types of rotator cuff tear that I found out.
A, B, C, D, and E.
Yeah, and I'm not going to go into full detail on them because a lot of people may not understand what we're going on about.
Yeah.
But like a type A is like a supraspinatus and a superior subscapularis tear. Type B, supraspinatus and an entire subscapularis tears. And so type C, supraspinatus, superior subscapularis, and infraspinatus strain. And there's more and more and more.
But I mean, what is the common pattern there? Supraspinatus.
Because it's the most
constantly there.
And I think infraspinatus makes up 15% of the rest of them, but like 70% are due to supraspinatus. And that's the muscle that allows you to raise your arm out by your side. And again, if you bring your arm over above 90 and you reach up, that's crucial when it starts getting pinched, isn't it? So it's not uncommon for it to get
I mean,
injured.
my experience, all right, when it comes to rotator cuffs, I had one today actually. We started off our treatments, so initially from the case history I was so convinced that it was a infraspinatus.
Okay.
Just because of the location of pain and everything else, and I thought, okay, I'm pretty solid on this. We did the treatment, got off the table, and you went, that's so much better. I can kind of feel it, but that's so much better.
Yeah.
Part of me thought, okay.
Flex.
No.
It's good.
Well, part of me was like, okay, yeah, you will kind of feel a little bit because we've worked on it. That's completely normal.
Yeah.
But I thought, okay, job well done. I'll leave you off to it. See how it goes. If it does come back or it creeps up, let me know. And surely enough, he ended up texting me. He said it hasn't quite gone away. It's still there. And then I went through it again. I assessed it again. And I went, okay, this is not infraspinatus at all. This was a subscapularis. And which is so easy to make a sort of mistake out of. Number one, because of their opposing movements.
Yeah.
So when you are moving one of them, the other one is an agonist as well as an antagonist. So no matter what you're doing, it's going to be
both activating.
Exactly. So in his sort of case, it wasn't the agonist, it was the antagonist. So from his bench pressing and his pressing movements with his chest, he was not activating the subscapularis on the left side, but he was massively on the right.
Massive imbalance created is causing strain.
And now he came off the treatment today and he went, actually I don't feel that same, it could be there again, whereas last time he did.
And subscapularis for me is one of the most crucially underrated muscles to treat.
It's fantastic.
I had to ask tutors at uni to show me a technique for it. And I get it as well because it's in the armpit of the patient, and I always tell patients, do you mind if I do this technique? Because you've really got to push deep, and it is horribly tender. Yeah. But if that muscle tightens up, that causes your shoulders to round. It stretches your rhomboids at the back. It can cause neck pain and everything. So working to stretch and release that is a great way yourself that you can do at home to prevent these things from happening.
To be honest with you, in my sort of day-to-day practice, if I believe there's a subscapularis involvement, I will dig into that.
Yeah.
Like there's no tomorrow.
I mean,
I say, I'm so sorry, this is painful, tell me if it's too much, but I am going to be a bit harsh on this.
Yeah.
And they'll go, do what you need to do, Doug.
I mean,
Let's go at it.
and I think we all need to look after our shoulders a bit more, because rotator cuff tears are prevalent in working age people. It's 30 makes up rotator cuff tears are in 30% of people. In people over the age of 75, it's in 50% of them. The supraspinatus alone, they did a study a few years ago with mechanics, and they were all over the age of 35. And what they found is 100% of them had a supraspinatus tear, and only 15% of those were causing problems. So again, it kind of shows just how prevalent this issue is, because we don't realise how much we use our shoulders on a day-to-day basis and how worn out they can get. And yes, if you go to the gym and you're causing imbalances, not doing a technique right, more likely to become injured. If you're right-handed and you write all day, that right shoulder is going to round a bit more and it's going to overstrain on that side, and blah 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 blah. And basically, it's very common. And so we need to be making sure that we give people the information, like we are now, on how to look out for it, how to prevent it. And a lot of times that's just through strengthening it yourself.
Yeah, and I mean, one of the things you mentioned as well previously was that 85 to 90% of rotator cuff injuries or frozen shoulder or any of these pathologies, you don't really need to go down a surgical route. You can just go through rehab, strengthen it up, and that tends to work very, very well.
Shout out to Massimo Barcelona,
Oh,
great
yeah.
physio. I think it's I don't want to say it wrong, SHP Health.
Yes, SHP, yeah.
Great CPD, but I remember talking to him, and also I spoke to a shoulder specialist surgeon, and they were saying, 85% of all issues in the shoulder, not just rotator cuff, but also degenerative changes, most people don't need surgery, and they're only having surgery because they won't even do the rehab, or they want the short way out.
Yeah.
Like a lot of people gun for the corticosteroid injection, because I've seen it when I worked on the NHS, and we've all seen it. Oh, I had shoulder pain, they injected it, next day pain was gone, I was so much better.
Yeah.
But people don't realise that only lasts 6 weeks to 6 months on a good way.
Back.
And then it'll come back, because it's not healing, it's just taking down the inflammation, producing a bit of lubricant. And I've seen it, and I had a patient come back and say, oh, it's back again. I was like, how was your rehab when you had the injection? I didn't do it.
Yeah.
Because as soon as people don't realise pain anymore, they go, it's better. And actually, it's when that pain originally goes. Pain's always the last thing to come on, and always the first thing to go. Function takes longer to come back.
Yeah. And so I had an experience of that where a patient of mine, I haven't seen him for a long while, and he said, oh, I had this injury, and I was referred for some physiotherapy, and that didn't quite go to plan, and then I decided to just go with surgery. So they did the corticosteroid injection.
Yeah.
They did 2, and absolutely 0 occurred. 0 relief, 0 pain. So it just was back to normal after a couple of days. And I think for him, it was really quite eye-opening, because I asked him, I said, oh, did you see anyone else? Like, you don't have to see me, it's absolutely fine. Did you see anyone else for some manual therapy? And he went, no, I just did some exercises.
Yeah.
And I went, oh, so you didn't go through the whole protocol of seeing what is available out there, seeing what occurs with other different types of treatment before you get, a needle stuck into your shoulder.
Yeah, I mean, it's that classic quick fix. I think some physios do it straight away and then give exercises, which is good. It's fine in that kind of aspect. But again, thank you to Massimo for giving us the information. But people get addicted to corticosteroids. It's such fast acting in a lot of cases, well, 50% of cases, that people go back for it, keep going back for it. But actually, by injecting corticosteroid, you're actually causing weakness in the shoulder. It can cause more damage to the ligaments and tendons supporting the structure, causing an increased likeliness of actual tearing again. And that won't get fixed through exercises after that. You're better off doing the rehab. Yes, it's going to be slow, maybe. Yes, it's going to take time, depending on the situation of your shoulder in, depending on degenerative changes, depending on tendinitis, depending, again, on the grade of muscle tear, which we haven't mentioned. So, sorry, I'm just going to dive into that now.
Go for it, yeah.
But there's about 3 types of tear, isn't there? So a type 1 tear you're looking at about 0 to 5% of the fibres being damaged. So very mild, probably more likely in someone younger. Yeah, and this is normally caused by overhead activities when you're younger, but can easily be fixed through exercise, a bit of rehab, bit of treatment, normally on your own. And there's no bruising, no real swelling going on or anything like that. Now, if you're looking at stage 2, you're looking at more of 5 to 95% of the fibres, big gradient, that gap, but that will take a lot longer. You will have some erythemas, you will have some bruising going on in the area as well. There'll be a bit of heat, there will be limited range of movement, there'll be pain at night, there'll be pain resting on the arm, it'll be made worse for activity, taking the arm above 80 degrees of abduction and all these things. And that will take time to first of all get the inflammation down through rest and recovery, through gentle movements, and then building up rehab slowly with that, from isometrics to concentrics to eccentrics to building up that way proprioception and all.
And actually, it's quite interesting to me because now that we have better technology in regards to diagnosis and assessment, so especially imaging, we have now been able to find out exactly how long it takes for these kind of injuries to be fully healed.
Like if we're talking a tendon.
Yeah, so we started, when we did our university courses, it was okay. We used to think maybe 6 to 12, 18 weeks. Now we sort of go, well, actually, it takes up to 2 years in order for just a simple strain of a tendon or ligament to fully heal.
Yeah,
fully heal.
Yeah, exactly. So it could be functional
and pain-free.
Because a lot of cases are. Because I remember reading a study back when I was at uni, is that it's finding a fine balance between functional and pain and where it gets painful. Because as I said, 100% of all mechanics over the age of 35 will have a rotator cuff tear, but only 15% of those are causing problems. They're all torn, but only some of them are being inflamed, only some of them are being overstressed. There is a point where it can recover back to a certain point where it's functional, but then it won't heal because, as I said, the shoulder's being used every day. It's going through those repetitive strains, so it's not going to be allowed to fully recover in some cases, but it can be managed, and preventative care can be put in place for it getting worse. But if you want it to properly heal, you've got to stop and all this there. And for a lot of people with work, you can't. So functional is better than nothing.
Yeah,
and it's common, and it's perfectly fine to function that way.
I completely agree. I think
if we probably looked at our shoulders on the microscope, we probably both have a tear in ours as well.
Oh, I massively do.
I was going to say,
I
from the
would not
gym.
be surprised. Exactly. I mean, for anyone who goes to the gym and trains quite vigorously, you will have aches and pains. And the thing is, yes, we could say those aches and pains are completely and utterly benign, but actually, if you look at it through a microscope, you will see that those aches and pains are little small signs of tears.
Oh, we go to the gym. Yeah, no, 100% micro damage, because that's all it is. And the reason why it takes so much longer with this to heal is because it's tendon, reduced blood supply. Whereas if you did a tear to your muscle, you would probably be looking at that 6-week to 12-week mark, depending on how bad the strain is.
So speaking of
stage 3, really quickly. Stage 3, complete tear, loss of function of that muscle, excruciating pain, no activation of a certain movement because that muscle's torn, a lot of bruising, a lot of swelling. Stay away from that one, guys. Sorry.
Stage 3, you're done out here. You're done.
That's surgery. You need reattachment.
Yeah. You need to go straight to A&E and just go under anaesthetic. I'm so sorry.
Yeah, you get that tearing, popping, snap sensation.
That's when your Rice Krispies.
Rice Krispies, snap,
crackle,
crackle,
and
pop. Oh, yeah, buddy.
Okay, so moving on to the next one is my favourite because it's such a common one. Everyone loves to call their shoulder injury a frozen shoulder.
Or otherwise referred to adhesive capsulitis, which I love whacking out in front of patients because they go, wow, this guy knows his stuff.
He is like mitochondria.
And like another word
the powerhouse of the cell.
God, jeez, bro, photosynthesis. But like, it's sick.
PTSD.
But glue is an adhesive, and the capsule of a joint, so the joint capsule, so adhesive capsulitis sticking off the joint.
And itis is inflammation.
Hence adhesive capsulitis.
So gluey,
glowy sticky shoulder. That's what I'm going to call it now. Gluey sticky shoulder.
pretty much.
You suffering from gluey sticky shoulder?
How did you know?
Looks gluey, man.
Looking a bit Robotronic.
But yeah, the amount of times I worked in the NHS as well, and I got patients handed over to me for frozen shoulder. Again, as I said, shoulders are tricky. A lot of times they weren't frozen shoulders.
And also
they were rotator cuff tears because they can be so rotator cuff tear and any impingement can be so debilitating early on. That can present as frozen shoulder.
Research. Okay, I'm going to throw this out there.
Okay.
Anecdotally, it could be slightly different.
Yeah.
But research based, unfortunately, there is absolutely close to zero form of treatment for frozen shoulder.
True.
Like, that is insane. However, anecdotally, from my experience, and I'm going to put this out there.
I'm going to put some out there as well.
So, yes, the frozen shoulder, I cannot do absolutely anything from my knowledge and research base to that frozen shoulder to make it any better.
Yeah.
Fact. However, can I increase the amount of movement of the scapula? Can I increase the amount of movement of the thoracic?
Can you decrease the amount of tension in the muscles?
And make sure that actually, yes, it could have a loss of function from a structural point of view, but can we increase biomechanics of the other joints around them in order to compensate and allow compensatory pattern to occur that could then eventually help for the frozen shoulder to get better at a faster rate?
I would have to agree. I actually had a patient not too long ago, I'd say about 3 months ago, and they had been, their shoulder froze up about three or 4 months before seeing me. They went online and researched how to treat frozen shoulder, and osteopathy popped up. So they came and saw me, and this thing had no movement. And I said to them, this is what a frozen shoulder is. I explained to them what that is, which I will do with you guys in a second, in a bit further detail. But I said, in the frozen stage, in the freezing stage, it's very painful. You're going to lose your movement. It's going to become more limited. I can't promise we're going to have any result through treatment because there's no study that says we can. But I've seen it before, and we can try and maintain strength in the muscles, prevent muscles tightening up. We can try and maintain some form of mobility, so as it freezes, we've still got you keeping some mobility, so it's not completely stuck by your side. And they were like, listen, I'm willing to do anything. So very gentle treatment early on. They literally had about 10 degrees of movement in all directions. And I gave them very gentle pendulum swings, try doing those at home, try ice over the area. And she was like, I'm doing some yoga as well. And I was like, fantastic, keep up with that. Week later came back, 15 degrees movement. I was like, wasn't expecting this. And they're like, pain's down a tiny bit, like maybe 1%.
Yeah.
Saw him again, come back the next week, 25% movement. And we started going like, this is getting better. I was being able to do more work on it, yes, working through the scapula and everything like that, and through the ribs, and I was working on the neck for all the reasons we discussed earlier. And then I said, right, I'm going to give it 2 weeks, give it a bit of rest from treatment, keep up the exercise, blah, blah, blah. Here's some more to do. Came back, 50 degrees range, doubled. And I was like, this is going really, really well. Again, continue to treat it. I don't joke, after we got a bit more movement out of it, after the treatment as well, we went through some broomstick exercises, went through some isometric exercises. So what that is pushing against an immovable object, so you're not really moving the joint, but you're activating the muscles to engage tone. We went through those, came back a week later, we had over 90 degrees flexion.
Nice.
We had almost full extension, we had increased internal external rotation, and about 90 to 100 degrees abduction.
That's pretty good.
It was insane.
The thing is, I think there is a lot to be said anecdotally about these things.
Now, by the way, a few more treatments down the line, we had it back to like 170 in abduction and they were like, yeah, I'm good to go. And pain was down.
The caveat to that is it will kind of plateau, and there's only so much that the treatment can sort of push you forward.
100%.
And then you that's when you just have to wait for the adhesive capsulitis to just heal on its own. I mean, full healing can take anywhere between 9 months to a year and a half, and sometimes even more.
And in 5 to 7 years following having an adhesive capsulitis, 10% of those people are likely to get it again.
And there's a discrepancy between men and women. So women will be 1 in 10, whereas men will be 1 in 12.
Yes, it's crazy. And other
Wait, did I say
women,
men and men?
Men, no, you went women and men. So women 1 in 10, men 1 in 12.
Yeah, perfect. Okay,
Yeah.
cool.
I'm pretty sure you said it right.
Yeah.
But at the end of the day, it's affecting 2% of the UK population, which people go, yeah, 2%, it's not a lot.
Million.
There's 70 million people in the UK. Yeah. So 1 million people a year. And in diabetics, 11% of diabetics will get this. And there's a reason for that.
Yeah.
Yeah. And there's also a reason.
Glucose.
Glucose, yeah.
Having too much glucose within the bloodstream means
Not producing enough insulin to break it down.
Which then causes a lot of the capillaries that are around the shoulder joint to be damaged, a lot of the nerves, quite a few different body parts are actually going to get damaged when it comes to having glucose, because this crystal is just free flowing around your bloodstream. And with that, you just increase for the amount of chance that you'll gain a little bit of gluey
sticky adhesions.
Yeah.
And that's through a process called hyperplastic fibroplasia, big words, and excessive laying down of type 2 collagen in the soft tissue structures that surround the shoulder joint as well, which cause it to stiffen up and tighten, causing frozen shoulder because no longer got the movement there.
Mm-hmm.
It's a completely idiopathic condition, which means they don't know exactly why it's caused. It just comes on like that. But the statistics are that people who suffer with diabetes, hyperthyroidism, I think it's menopausal.
Yeah.
Women.
Because of hormonal reasons.
Yeah, exactly. Are more likely to suffer with this, generally over the age of 40.
Mm-hmm.
And also if you've had previous trauma to the shoulder and other systemic health conditions, much like the hyperthyroidism and
but people
diabetes.
can wake up with this.
And that's the thing, it can just come out of nowhere.
Wake up and they go, I can't move my shoulder.
Yeah, and as we kind of hinted at earlier, there are 3 stages of a frozen shoulder. Stage 1 being freezing.
Freezing.
Yeah, so that's where you're getting a lot of pain.
Mm-hmm.
And your movement is dropping drastically through the shoulder.
Yeah.
Stage 2,
sorry,
frozen.
You caught me completely. I'm at a point where I'm like, okay,
to be fair, we
blank.
are recording at about 8:30, 9 at the moment. So.
My brain just went completely blank. I'm so sorry.
We've done this in a couple of episodes where one of us has just come at each other and the other one's just gone,
We do know it,
We
but
do know it, so
at this moment in time, it does slip our tongue and our brain.
And so freezing can take up to 1 to 3 months to happen. Normally, it can take a little bit longer. Frozen is where, you've got adhesive capsulitis. That joint is stuck. It's not moving. Pretty much, you've lost all range of movement, especially internal, external rotation and abduction.
Mm-hmm.
Be limited. And then you've got the 3rd stage. Gotcha. Thawing. So where it's starting to defrost. And no, I don't mean whack a hairdryer on the area. That ain't gonna work. It's not that kind of frozen, but it just starts naturally freeing up, and it's mind blowing. It's like, well, what car's that?
Well, the thing is, as I kind of said before, there is absolutely zero understanding as to how to treat it.
Yeah.
So when that occurs, and we don't really know what causes it, it really does stump everyone.
And then people go to the idea of, let's inject it. Let's do a hydrodilation therapy.
It doesn't work.
Which is pretty much sticking cortisone and saline into a joint to try and reduce inflammation and free it up. So it's just pumping the joint full of fluid to open it up.
But there is no research to suggest that works.
Or it has any effect. There was one bit of research that I read that there was a case where it was completely in the mind, frozen shoulder, and when people went to sleep, their shoulders had full range of movement.
Yeah. So what they did was they put someone under anesthesia and
Yeah.
they tried to move it, and there was absolutely zero movement.
But there was an actual case where the person fell asleep and they got full range of movement. As soon as they woke up, it froze.
Wow,
So you explained that.
that is wild.
And then there was also a surgery where they will physically rip the joint, put you on anesthesia and rip the joint back to break those adhesions to free it up.
Yeah.
So it's an actual treatment method.
Did it work?
Brutal, but it's difficult to say because the muscles are still tight. Maybe
Yeah.
you gain a little bit of movement, but not enough.
It really is a matter of what is the worst possible thing that you can imagine that you want to try and do in order to treat. Look,
Like this,
just do
always
the rehab. See a manual therapist, do the rehab.
give it time.
Exactly. Be patient. You don't need to like absolutely kill yourself to try and treat this.
Keep it simple.
Ladies and gentlemen, have...
Well, no, we're not done.
Oh!
We're not done. I'm just saying keep it simple because that's the name of the episode. We've still got impingement syndrome, which we discussed a little bit about at the start, but we need to talk about one very, very crucial thing I see all the time at clinic at the moment. Acromioclavicular joint.
Okay, cool.
So that's where your shoulder blade and your collarbone attach. The collarbone being the only bone in the body that attaches your shoulder to the rest of the body.
Why?
Because everything else is muscular attachments.
We do have a fake joint though. Scapulothoracic.
Oh yeah, that's true.
It doesn't attach specifically in regards to a joint itself, but it's called a false joint because it's so heavily attached and flat to your thorax that actually they kind of see it as a half joint.
Did not know that. So there you go, teaching me things.
Yeah.
So the acromioclavicular joint, also known as your AC, everybody's got one. If you run your fingers over your shoulders, you've got a little bump at the very top on the superior aspect of your shoulder. Now that is known as your AC. If you push around there, you go, oh, that's a little bit tender. You may have a bit of AC degeneration. It's like having grey hair. When you get older, you're going to have a bit of degenerative change, and it is the most mobile joint in your body. And the chances are it's going to have some degenerative change, which means lying down bony tissue, which means it's going to get inflamed and irritated because the joint surface is broken down a little bit. It also means the space underneath is going to become smaller, leading to further impingement. What can you do for it? Strengthen the muscles up around the area and...
Rehab.
Yeah, by strengthening the muscles up around the area. And also treatment.
Yeah, sorry, I was gonna add that on top of that little feeling that you'll get at the top of the shoulder is actually a very common thing. If you guys want to have a look at pictures, because it's really, really cool. It's called the shoulder piano key.
Oh, okay.
The piano key sign. So if you have a little look at that, it's literally the coolest thing ever because it's just...
Well, describe that.
Yeah, it's like a piano key.
Oh.
It's like it's a corner and it literally just drops down.
Okay, because I've got that.
Yeah, that's not as significant, but there are people with really bad ones.
Isn't that due to dislocation though?
Not necessarily.
Because that's a step.
Yes, but actually it could also be degeneration due to the occupation that you've had.
Okay.
So a lot of painters will have it, a lot of construction workers, because of the continuous movement going up and down.
Overhead especially.
Overhead, you essentially start to create that huge step. So I have a client who I've treated now a couple of times and I've known for many years, and he is a renovator.
Okay.
So he does a lot of painting. Right side has this huge piano key, completely functional, no problem whatsoever, but just there.
I mean, yeah, and again, it can be functional. And as I say, I just see it a lot at the moment, and it's going to cause pinching of that gap, especially I see it mainly in people who work at desks nowadays as well, especially after maybe they're over the age of 50. We've had that degeneration go on a little bit more. But cases, just get it moving, open up, strengthen around the area, bring those shoulders back, apply a bit of ice if it's sore, but it gets better. Actually, I know somebody who's actually just gone in for a shoulder replacement operation for that joint.
Wow.
Because they're not the most successful. This one luckily was, but technology is getting better because it's so hard to create and the acromioclavicular joint, that was perfectly, because there's so much movement there. It's not like a hip where you just pop it in a socket.
Yeah.
It's a very open joint.
Yeah, and I mean, when you look at the structure of the shoulder joint compared to the hip joint, so the hip joint, it sacrifices range of movement in order to increase stability, whereas the shoulder joint sacrifices stability to increase range of movement.
Yeah.
And that just kind of gives you an understanding of the way the two joints are. So the shoulder joint is essentially like a golf ball on top of a.
It's almost like a saucer for a cup.
Exactly, it's so tiny
So
compared
open.
to.
It's only a small dip.
Yeah.
But I think that's a good place to call it, because we've discussed the 3 most common forms of shoulder injuries. We've discussed impingement syndrome, which things like rotator cuff tears, acromioclavicular joint, and other things like bursitis and tendonitis come involved. And again, they fall into the rotator cuff aspect as well. So basically, if you've got something going on your shoulder, if it's not frozen shoulder, it's probably impingement of some form.
And the thing is, the best thing you can do is just speak to your therapist.
Speak to your osteopath, your physio, your chiropractor, any of your healthcare professionals, GP. Just get somebody to assess it, run the right tests, and give you an idea of what's going on, and do your rehab.
So, guys, you've just had
That was so cool. So, guys,
36 minutes of lovely information.
pure information.
36 minutes with a little bit of flustering, especially me. I'm so sorry, guys.
It's alright.
But
It's
yeah.
okay. I mean, I've been flustered many a times before. I've also been having my mind on the cheesecake I'm going to go have after this.
Oh,
Cheesecake
have a good day, guys.
and shake and bake.
Ciao for now.
Ciao for now. I'm going to press pause right here. Oh, I started.